Now let's move on to some pathologies that don't affect the glomeruli directly. The first one is kidney stones, also called nephrolithiasis. This results from precipitation of some kind of crystal in the collecting systems of the kidneys, and it can lead to complications like hydronephrosis, which is atrophy of the renal tissue due to compression by urine that can't flow out. And it can cause pyelonephritis because less urine is able to flow out, so it makes it easier for bacteria to establish infections that can move up the kidney. The pain is usually unilateral because usually patients just have one kidney stone, and there's unilateral flank tenderness. This pain usually radiates to the groin. Because patients have this stone in their ureter or somewhere in their collecting system, there can be some bleeding and patients can have hematuria. Now, will there be RBC casts? No, because the problem is occurring after the renal tubules, so the RBCs won't be able to form casts. Now, you want to treat the patient for the stone, and we'll talk about the different types of treatments because there's different treatments for different stones, but all patients should be encouraged to increase their fluid intake so that they don't precipitate more kidney stones. So there's 4 kinds of kidney stones, each with its own special characteristics. By far, the most common are calcium-containing stones, either calcium oxalate or calcium phosphate, or both. And they occur in conditions associated with hypercalciuria. For example, ingestion of ethylene glycol leads to calcium oxalate formation. Calcium oxalate. Because ethylene glycol is metabolized to oxalic acid. Vitamin C abuse can increase urinary excretion of oxalate, again leading to calcium oxalate stones. Now, why is there an increased calcium oxalate stone formation in Crohn's disease patients? The answer is because they have fat malabsorption. And the fat stays in the small intestine and binds to calcium. Therefore, the calcium is not able to bind to oxalate inside the small intestine because it's bound up by all the fat. And the oxalate then gets absorbed because it's not precipitating as calcium oxalate. And with all that oxalate in the blood, it's going to get passed out through the urine. And in the urine with a high concentration of oxalate, we get precipitation of calcium oxalate stones in the urine. Now, it's helpful to remember that calcium phosphate precipitates in increased pH, and calcium oxalate precipitates in decreased pH. So treatments will include thiazides, which, if you remember, do what to calcium excretion? They reduce calcium excretion. Citrate, which binds to calcium to prevent its precipitation in the urine. And remember that these stones will be radio-opaque, meaning they can easily be seen on X-ray or CT, and that will help in the diagnosis. Alright, the next type of stone is the monster stone. This is the ammonium magnesium phosphate stone, also known as the struvite stone. These occur when there's increased pH of the urine, abnormally increased. And this is caused by infections with urease-positive bugs. And these urease-positive bacteria break down urea to produce ammonia. And that ammonia is what increases the pH by binding to the hydrogen ions. The usual bacteria, the urease-positive bacteria that cause the struvite stones are Proteus mirabilis, Staphylococcus, or Klebsiella. Now these staghorn calculi are massive and they can form a nidus for urinary tract infections. Treatment includes antibiotics for treating the infection and getting rid of those bacteria, and surgically removing those stones because there's no way to urinate that out. And as seen here on X-ray, they are radio-opaque. Next is uric acid stones. These occur in conditions that increase uric acid excretion, such as gout or leukemia, where there's increased cell turnover and uric acid production due to purine metabolism. Now, risk factors for uric acid stones include anything that's going to decrease the urine volume, like dehydration, or make the urine more acidic, like an arid climate. These stones are special because they are radiolucent, meaning they can't be seen on X-ray. However, they can be seen with ultrasound or CT. So what's going to be the treatment if a risk factor is acidic urine? Alkalinizing the urine to treat these stones and dissolve up that precipitated uric acid. Finally, there's cystine stones, which are very rare, but can occur in the context of genetic cystinuria, so they're mostly seen in children with cystinuria. They can also form staghorn calculi, those big stones that we saw earlier. And the test for cystinuria is the sodium nitroprusside test, which will be positive if there's cystine in the urine. These stones are radio-opaque, so you can see them on X-ray, and they precipitate in decreased pH, so we're going to treat by alkalinizing the urine. A man with flank pain and hematuria comes in. X-ray detects no kidney stones. Urinalysis shows acidic urine and crystals. Which kidney stone is this? The answer is uric acid kidney stones. The way I like to remember it is the U in radiolucent tips me off that it's a uric acid stone. And both the presence of the acidic urine as well as the crystals and the fact that it was radiolucent, we didn't see anything on X-ray, all point to it being a uric acid stone. Now, one of the complications of kidney stones is hydronephrosis. And this is a condition that results from partial or complete obstruction of the urinary tract. So what happens is pressure builds up behind the obstruction, and you can see this patient has hydroureter and hydronephrosis. The ureter is bulging out, and the kidney parenchyma is becoming compressed due to the pressure buildup, and this causes atrophy of the cortex and medulla. Now, the obstruction can be due to renal stones, benign prostatic hypertrophy, cervical cancer, injury to the ureters which will cause scarring, retroperitoneal fibrosis, or vesicoureteral reflux. Basically, all of these things are going to compress and obstruct urine flow, causing that buildup of pressure and atrophy of the tissues.